like to introduce myself. I'm Caroline Dooley Martin, Director and Chair of the PSP Association Ireland. People probably know it better as PSPA Ireland. So today I'd like to introduce Dr. Sean O'Dowd. Sean O'Dowd is a clinical neurologist in Tala University Hospital, and he's been very kind to come along today to answer a few questions on PSP. So thank you for coming along.
Thanks for
And first question I suppose I'd like to ask is, what is PSP? It's not a very common disease, and
yeah, absolutely. So so PSP is it stands for progressive supranuclear palsy, which is a very kind of long-winded medical term, I suppose, but essentially it's a brain disorder characterized that the patients will experience some symptoms that can have features like Parkinson's or Parkinsonism, as we would say, but also with sort of additional features often affecting, you know, kind of balance and gait more prominently and early than typical Parkinson's disease, as well as sometimes cognition, personality. You know, so I suppose a more advanced or like a different type of experience to what Parkinson's disease is itself. And the term, I suppose, progressive refers to the fact that it is a neurodegenerative disease. So it's something that slowly gets worse over time, for which at this point we still don't have any, you know, disease modifying treatments or treatments that can stop or reverse that. But that's, you know, I suppose one of the holy grails in research. And supranuclear palsy really refers to the eye movement disorder that can often be part of this type of symptoms and signs that the patients present with. It's not always the case, but it's, you know, one of the early defining features when the neurologists in the 1950s and 60s first started to describe it. So that's where the term comes from. And I suppose as research has gone on in the last few years, we've realized that, you know, there are different types and forms of PSP, that it's not always that sort of typical presentation, you know, where people present with the trouble with the eye movements and the falls, that there are variant kind of versions of it. And you make the point that it's rare, and indeed, I suppose it is, but it's perhaps not quite as rare as, you know, as some might think. You know, the kind of the data from the studies, the prevalence studies that have been done in places like the northeast of England or over in Minnesota would suggest that it's probably nearly as common actually as things like motor neuron disease, which I think there's a lot more sort of public and recognition of and greater awareness even of in medical circles. So it is rare, but it's probably not maybe quite as rare and is called perhaps other things for some time before it's definitively identified as the condition that somebody has. So I suppose that's sort of the background of where the name comes from and what it is in terms of the symptoms that people have. In terms of what causes the brain condition, it is caused by abnormal behavior of a normal protein in brain cells, and that protein is called tau, and that's a very normally present thing in brain cells and in other cells, but for some reason that we don't really fully understand, in PSP and in some other brain conditions, the tau protein begins to behave abnormally. So it starts to sort of fold and clump together, and that causes damage to the nerve cell function, and that's what leads to the trouble and the symptoms that patients have.
Okay, and can I ask you if it is inherited? I know it's a question we get quite frequently.
By and large, only with vanishingly rare exceptions, it's not a disorder that's inherited in a kind of classical sense, the way that blue eyes or red hair or what have you can be inherited. So it's what we call a sporadic disease. In other words, something that just happens. We don't really know why it just happens. It is associated with aging, I suppose, and that's possibly a contributor for some reason to why the protein begins to behave abnormally. But it's not something that runs in families. I mean, they're extremely rare, families out there, I mean, of which there, probably just a very small handful in even the UK and Ireland put together, where there are mutations on the gene that makes tau, where it can be passed on, but they're very, very different to the sort of the typical presentation of somebody who comes to the clinic and is diagnosed with PSP, who's usually from their 50s, 60s onwards, whereas the hereditary forms are often more severe, present earlier in life, and there's a very strong family history.
Okay, that'll be a benefit to a lot of people. I think a lot of people worry when they hear of a rare condition, are they going to pass it on? So this is a common question we get.
Yeah.
And
so the answer is virtually never, really. I mean, it's vanishingly rare for it to be passed on.
Yeah. And the other thing, corticobasal degeneration. I know that's another condition that people have, and I think sometimes people feel that it's different.
Yeah, I guess it is in many ways, but at the same time, I suppose there is a fair bit of overlap. I guess, so corticobasal degeneration, again, it's another one of these conditions that we call tauopathies. So that this tau protein is accumulating and behaving abnormally in brain cells. There are some features about it that distinguish it or make it make the symptoms experienced by the patient a little bit different, but the conditions can overlap quite a bit too in terms of the experience. I suppose typically people with corticobasal degeneration will tend to have very, classically, I suppose, very prominent symptoms and signs with one side only at the outset, like typically an arm, sometimes a leg that's not quite behaving itself and has become very stiff, or they've, trouble using or getting it to do what they need it to do for themselves. And I suppose, there can be some more kind of features with cognition early on, with speech particularly, can be something that can be an early feature with corticobasal degeneration. That being said, I suppose, as time goes on and as the disease progresses, it can begin to affect, both sides of the body as well. So in some respects, it has an overlap with PSP, and unfortunately it's like PSP, it doesn't really respond in terms of the Parkinson's type symptoms, which would be like tremor, stiffness, slowness of movement. It doesn't respond as well as typical Parkinson's disease does. So it would have that in common as well with PSP.
Okay, and when somebody has either of these conditions, getting a diagnosis can be difficult. So I think we would recommend that people see a neurologist, and maybe you would explain how it's diagnosed.
Yeah, absolutely. I mean, it's well charted and documented that getting a diagnosis of PSP or of CBD can be quite, a turbulent and a long journey for patients and families. And there's, again, this has been looked at in both the UK and in the US and other European countries, that many patients will have a journey, so to speak, of 2-3 years or more before a diagnosis is reached, and have seen maybe a number of specialists sometimes before a diagnosis can be reached. And I suppose in some ways that's not always a criticism of somebody who may not have identified it earlier on, because I suppose it can evolve and become more obvious as time goes on. But there's no doubt that it is something that it can, evade a clear label for a long time, which can be very frustrating for people. I guess how the diagnosis is made, I mean, largely, I suppose it's made on what we call clinical grounds. So it's the symptoms that the patients describe, it's the physical signs that they have when we see them and examine them. And we have what we call diagnostic criteria, which are, a sort of a list of symptoms or signs that are quite specific for PSP or for corticobasal degeneration, and that will sort of take account of certain features of the conditions that you would not see in typical Parkinson's disease, or in Lewy body dementia, or in Alzheimer's disease, or some of the other kind of neurodegenerative diseases that can, sometimes look a bit like it in some respects. So I suppose it's a clinical diagnosis, which can be aided in some ways by some, other tests, like, for example, an MRI scan can be helpful. There are some features in an MRI scan which can be, quite supportive of a clinical impression that somebody has CBD or CBD, or PSP or CBD, I should say. But I guess that's another sort of thing about these conditions, that we don't have, what we call very robust biomarkers, and that meaning, tests that we can do on scans or on lumbar puncture fluid that gives us, a cast iron guarantee that what the patient has is PSP or CBD. So it's clinical largely, but supported by the tests that we can do.
That's a very important part. I think that, you know, that people understand that it's not that simple to diagnose, and that a lot of tests have to be done really to come to a diagnosis, that it does take time. And I think a lot of people would experience that and in managing it, managing the condition then and treatment.
Yeah, so I guess
advice there.
I mean, I suppose for, you know, I suppose the treatments that we have are focused on the symptoms that patients experience, and trying to make those symptoms as manageable as possible, and make, you know, day-to-day life as easy as possible for patients and for their families. And unfortunately, as I said earlier on, at this point in time, we don't have a treatment which, you know, modifies the progress of the disease, as in slows or halts it or reverses it. But, you know, I think that's very much a sort of a work in progress, you know, worldwide. So, you know, the symptomatic treatments are, you know, based around what the patient is experiencing. So I guess from the point of view of the you know, the Parkinsonism, so the slowness of movement, stiffness, tremor, and trouble with balance, we typically will use levodopa, which is normally Sinemet or Madapar is another kind of version of that. Now the response, or how much benefit patients with PSP will get from levodopa, is fairly variable. I mean, I guess there's a group of people, you know, a sort of a subtype of people we call PSPP, with prominent Parkinsonism, who can get, you know, quite a good response to it early on, at least. For others, not so much. But what we do in standard kind of clinical practice, you know, with these patients, is we give them, you know, good high doses of levodopa that wouldn't normally be used, you know, in Parkinson's disease, or certainly not early on in Parkinson's disease, in order to, you know, get as much out of it as we can, so to speak, you know, particularly for balance and for kind of core sort of axial stability. And then it's a question of really seeing whether that's helpful or not. You know, for some people it is, for others not so much. For some people, the side effects on the higher doses can be a problem, and if it hasn't been helpful, then we kind of roll back on that. For other people, I guess there isn't much of a side effect problem, but the tablet hasn't hugely helped. Practice can vary a little bit then as to whether people are left on it or whether it's withdrawn. I know, you know, anecdotally, I've had a couple of people, and I know from a couple of colleagues, that feel that it hasn't been hugely helpful. You withdraw it and it doesn't make any difference. But similarly, there are people who feel maybe that they didn't get much out of it, but when you withdraw it, might find that the balance has gone off a bit. So I think, you know, as I say, it often, you know, does lead early on, certainly, to people being put onto fairly considerable doses of levodopa. But in practice, I find most people tolerate that fairly okay. I guess then, you know, there are lots of other symptoms aside from the Parkinsonism, you know, from the perspective of, you know, like, I guess, trouble with double vision and visual disturbance can be quite salient and prominent, particularly in PSP. And people can have trouble with tolerating light, or can have double vision, and there are, you know, sort of optic or orthotic, you know, aids to make that a bit easier. Some patients can have trouble with getting the eyelids to stay open, and again, you know, there are, you know, kind of mechanisms to treat that, and ophthalmologists will sometimes use a bit of botulinum toxin or Botox to stop those muscles from being overactive, so that it makes the eye opening a bit easier. Drooling can be a problem. There are treatments for that if it becomes an issue for people. And I suppose, you know, cognition, broadly speaking, it can certainly be something that we recognize quite a lot of difficulty with in PSP and in corticobasal. And again, I suppose at this point in time, mostly it is the cognitive therapies that are used in things like Alzheimer's disease, we feel don't help, you know, particularly for the cognitive symptoms of PSP and CBD. But again, there can be a little bit of trial and error with that, I suppose, for an individual patient. Mood and kind of anxiety and kind of mental health symptoms, I suppose, very common as well. Whether I guess you know, they're part of the disease process, or whether they're at a very natural and to be expected sort of response to being diagnosed with a difficult condition is debated, I guess. But I suppose I feel it's something that's always worth chatting to patients and families about, because while we might necessarily have phenomenally good treatments for some of the symptoms, mood is something that can be treated fairly effectively. And I guess there are elements then that might be a little bit more specific to corticobasal. The jerky kind of tremor the patients describe that we call myoclonus. There are a couple of treatments that can be helpful for that. And I guess then there are kind of supportive treatments aside from medicines and drugs, which are really important for both. And by which I mean, physiotherapy that's kind of targeted to the specific difficulties that the patient has, occupational therapy for kind of making day-to-day life and life in the home a bit easier, and speech and language therapy for speech disturbance, which can be a feature of both these conditions, and in order to assess and look at swallow mechanisms.
Yeah, that's great. And I think what comes out of that, it's quite obvious that it's very important to see your neurologist to get your diagnosis, and then be sure to talk about the symptoms and mention them to your GP and your consultant when they arise, and not to wait, because I think a delay.
Absolutely. Yeah, I think so. And I suppose I think it's important to say that that there are lots of patients out there, I think, who kind of are soldiering on, so to speak, and maybe are, they may have very long gaps between appointments sometimes with at neurology clinics, although hopefully I think in some centres like my own clinic, we try to avoid that. And I think most of the neurology units, certainly our own in Tallaght, we have, a clinical nurse specialist who's available as a point of contact for patients and families, with PSP and corticobasal. And that's often a very useful resource, and can give some advice to kind of try and help out with things in between appointments.
Right, it's great to have that backup, really. And I suppose, and one more question then, in terms of research, is there anything going on in research? I know a lot of people are interested in research, and there isn't always big numbers in rare diseases to accommodate research, or even to generate the interest.
That's true. Yeah, I think that's true. I mean, there however, like at a global level, there certainly is, and locally, I mean, we're hoping to get a project off the ground later on this year, actually, that I can chat about. I guess the research is sort of it's very much focused and on, well, I guess there's the kind of the biochemistry, if you like, so the nature of tau protein and why it's folding and behaving abnormally, and can that be targeted in some way with drugs that can stop that from happening and stop the abnormal from protein from accumulating. And there have been a couple of clinical trials which have targeted that tau protein and certain elements of it without great success, but it's still a work in progress, because I suppose what we know from other diseases brain diseases that are caused by abnormal protein aggregation, there are different ways to sort of target that, and that's still ongoing. Locally, I guess, it's something that, I did a postdoctoral degree many years ago now with Tim Lynch in the matter, and it's something I suppose we've been talking about in many respects since then, but that we're really hoping to do, within the next 12 months, is to do what we call an epidemiology project in Ireland, and that is to try and identify all the patients that we have who have this condition, and just to, I suppose, describe their their condition, the nature of it, because as we said, there are a couple of different kind of subtypes of PSP particularly, that we recognize, because I guess as somebody much smarter than me that once said, if you can't measure it, you can't manage it. So we need to have a better kind of database, if you like, or registry of patients out there who have this condition, so that we can basically have people identified and ready to go if they're willing for research studies or for clinical trials if and when, you know, one was going to be launched in Ireland, you know.
Yeah, I think that's great. That's fantastic news as well, you know, and I know that it's something that a lot of people are interested in, research here in Ireland, a lot of our members, but it hasn't always been open, and it's great to think that something could be done here, because we don't really have any statistics for Ireland, so it'd be lovely to know that something like that could be done, and I think it will benefit all of us, you know, in finding maybe answers to this condition.
I mean, I suppose in terms of, you know, there are a number of us with, you know, with kind of particular interest in it in the country, and you know, Tim Lynch, of course, would be well known, I think, probably to a lot of your patients, and you know, certainly this is kind of a collaborative project between a few of us, including Tim, myself, and a couple, Tim, Richard Walsh, and a couple of others who have an interest and would look after patients with this condition. So you know, it's something I think that will lend itself hopefully to fairly, you know, good data for the conditions for you know, for Irish purposes, and we collaborate and hope to collaborate further with other particular, you know, European centres, so that we can kind of pool experiences and maybe identify things that can be studied and that might lend themselves to future kind of trials and so on.
That yes, definitely. I mean, that would be brilliant, and it can tie in more with a lot. I mean, there's a lot of research going around the world in PSP, but they're all in sort of different countries, and in one way to get an overall picture of the condition might help us to move forward with the condition and understanding and treatment. And I think that's great for, certainly for the PSP Absolutely. Community as well.
Yeah. I guess I feel the PSP and CBD are conditions that are sometimes a little bit neglected, you know, because of their perceived rarity. And, you know, the more that we all do as doctors and as you know, so, you know, in the PSP Association to try and raise awareness of these conditions, you know, the better. And it's something I'm very happy to you know, participate in any efforts like that at all, really. You know, I guess to my mind, a really good example of a relatively rare disease that is well supported in Ireland through very hard work is motor neuron disease, you know, and a lot of hard work went into that over the last few decades from Orla Hardiman and her colleagues. And I think it's something, you know, a template, if you like, that we can sort of learn from and mimic in order to raise more awareness and get more, you know, kind of research and support in for these conditions. From a practical point of view, I suppose, you know, as these conditions advance, they can be quite troublesome for patients. That, you know, they can really lead to a lot of impact on quality of life, and you know, it can become very difficult for caregivers to provide the complexity of care that some patients need. So that's something that we have, you know, been conscious of. So myself and Stephen Higgins, who's a consultant in palliative medicine in Tallaght, have received funding from the HSE for a fellow in neuropalliative care, which we're hoping to recruit into from July. I mean, I think people understandably sometimes kind of balk or feel nervous when they hear the term palliative medicine, but I suppose these are the services and our colleagues who look after people with life-limiting illnesses, and that's not always, you know, a cancer diagnosis by any means, and it doesn't mean that life is limited next week. You know, it's about trying to optimize quality of life and symptom management. And you know, my view on this is, and we know this from motor neuron disease, is that probably the earlier that the palliative services get to know the patient and the family, the better. They may not need to do or offer a huge amount at the outset, but they're, you know, they're experts in kind of guiding symptomatic care and in some of the kind of the difficult chats and decisions that people, you know, might need to do and make as time goes on, that you may not always feel that you've had the time to get through properly in a neurology appointment in a stretched system. So so, you know, that's something that I think will prove to be, I hope, very helpful, because it's not a particular you know, subspecialty that's hugely developed in Ireland, you know, palliative care in neurological disorders. So as I say, we have funding for somebody who's trained in palliative medicine to take this on from July, and hopefully we'll be interviewing for that in the next couple of weeks, and hopefully we'll have somebody who will be slotting into the role in the summer.
Oh, that's wonderful. Yeah, that is great, because I mean, I know palliative care early intervention is recommended in PSP because of the trajectory of the diseases, so unpredictable. And certainly from anybody I know who've been through the palliative care system with PSP, they felt really well supported. And I think it looks at the person, which is so important, and helps them on their way. And for the carer as well, it's a very great supportive system. Yeah.
So we'll keep you posted on that.
That's fantastic. Thank you very much, Dr. O'Dowd, for talking to us this evening. Absolutely wonderful. Thank you very much.